So this year across Australia and New Zealand, we have over 9,000 hip fracture data sets that allow us to convey a lot more information than we've been able to in the past. When we look at the population that we're studying, we're talking about a group with an average age of 84 years of age. 70% of them are female, 30% come from residential aged care, and 40% of them already have underlying cognitive problems prior to admission to hospital. So this year, there are a number of points worth highlighting. Firstly, in terms of management of pain, something that is very important from a patient perspective when they present to the emergency department with a hip fracture. At the moment, only 54% of people are actually having their pain assessed and documented within 30 minutes of admission to hospital. What we are starting to see now is an increase in the number of people who are offered a nerve block. So that's a local injection around the site of the hip fracture, which numbs the site and relieves pain. But there is a lot of variation between hospitals in terms of who is getting a nerve block. And it ranges from anywhere less than 10% in some hospitals to over 90% in other hospitals. So clearly there are opportunities for us to learn from the hospitals that are doing particularly well. Time to surgery remains a challenge. 77% of people are being operated on within 48 hours of admission to hospital, which is positive. But nonetheless, it still means 23% are waiting over 48 hours for surgery. The most common reason remains access to theatres, something that we can and should do something about. Secondary fracture prevention remains a concern. These are a high-risk group of individuals who are at risk of further falls and fractures, and we know and have strong evidence out there that we can potentially reduce their risk of future fractures. This year we've seen a small increase in the number of people leaving hospital on treatment for osteoporosis. So it's increased from 16% in 2017 to 24% in the 2018 report. Now that's great to see the improvement, but it still suggests that we've got a long way to go. In terms of preventing future fractures, there's two approaches you can take, and both are important: preventing falls and treating osteoporosis. We've had a number of medications available for decades now, where if we administer them, we know it is likely that we will reduce people's future risk of fracture. It's important that people know what the basic building blocks of bone are. All of us should be taking regular exercise in relation to bone health, and our diet should be adequate in calcium and vitamin D. Most of the vitamin D we get in this country comes from sunlight exposure, but as you get older, your skin's ability to synthesize vitamin D decreases. There are many older people who get very limited amount of exposure to sunlight and will be vitamin D deficient, yet it is a very simple thing to put right. Calcium is something that's found predominantly in dairy products. Again, easy to access, also found in green vegetables, but there are people whose diet again is deficient in calcium and relatively easy to correct with calcium supplementation. When an older person is admitted to hospital with a hip fracture, the team that look after that patient are really only there for a very short period in that person's life. When we're talking about future fracture prevention, it is key that the GP is involved in that plan and that the individual consults with their GP to come up with a plan that is individualised and suitable for their needs. That long-term relationship that patients have with their GPs is critical to secondary fracture prevention. This year we've produced a booklet designed specifically for patients and answering commonly asked questions about the hip fracture journey. How will my pain be managed? What happens if I become confused? When will I have my surgery? How soon will I be able to get up and walk after the surgery? How long will I be in hospital, and where will I go to after my hospital stay? Equally important in this booklet is the need to have that conversation with the GP around future falls and fracture prevention. In the 2018 report, we have a new feature where we have looked at two populations and access to rehabilitation. Firstly, people coming from residential aged care. Only 18% of people who come from residential aged care are actually referred for rehabilitation. What we're unclear about at this point in time is whether these people are being denied access to treatments from which they benefit, and this is clearly an area of future research for us. The other group of individuals, equally important, are those with an underlying cognitive impairment. Again, about 34% of individuals who are cognitively impaired prior to admission to hospital with a hip fracture are referred for rehabilitation. Again, this is underrepresented in terms of the people who do access rehabilitation, and again asks the question, are we precluding an important group of individuals from rehabilitation? Again, we cannot answer the question from the data we have at this point in time. It's an area for further research. Each year in Australia there are approximately 22,000 hip fractures. The rate of hip fracture looks like it's plateauing at the moment, but the change in our demographic is such that there are more and more people coming through our emergency department doors every day with a hip fracture, and that trend is set to continue into the future. Currently, we spend about $1 billion a year on hip fracture care. From a patient perspective, prevention is far better than managing the hip fracture.